You're muted,
Doctor-
Attorney Kurz. Oh, there you go.
Doctor, has St. Vincent's Medical Center,
Hearing
Quanti-
officer Hens, I'm sorry,
Yes.
Attorney Kurz, I'm just trying to fix the camera so that it will show.
By this way, to the
You
right.
could, yeah, if you just give us a moment, I'm sorry.
Sure, that's okay.
Yeah.
There we go. Okay.
There we go. Sorry about that.
thank you.
Yep.
Doctor, has St. Vincent's quantified the number of occasions where there's been a poor clinical outcome associated with a delayed transport?
I am not aware of that information.
Does St. Vincent's have any information that quantifies the frequency of additional infections or pressure injuries or other clinical manifestations of problems associated with delayed transports?
Sorry, I would be speculating. That may be a better question.
I don't have any further questions for this witness at this time.
Okay. Thank you, Attorney Kurz. Attorney Langer, any redirect?
Yes, just a couple of questions.
Sure, you may proceed.
Thank you. Dr. Jandro, you had testified regarding the shortage or in response to strike that. You had been asked a question by Attorney Kurz regarding the shortages of EMTs, and you had provided a response saying, no. Could you please clarify what you mean by that?
Yes, I do think that across the nation, there is a workforce shortage of EMTs and paramedics. I am aware, and involved with Hartford Healthcare's robust training opportunities for EMTs and paramedics that bring very highly qualified, well-trained EMTs and paramedics into the workforce in Connecticut.
Okay. And so when you were referring to there not being a shortage, how does that relate to, the robust training that Hartford Healthcare implements?
I am confident that we would find very qualified candidates for these positions through our robust network of training programs, including EMT and paramedic training.
Okay. You were asked a question as to whether there are any particular efficiencies related to this application. And you had mentioned not having PSAR obligations. Is that correct?
Yes.
Okay. How would the location of the proposed branch 2 miles from St. Vincent's Bridgeport campus be an efficiency in your opinion?
Yes, certainly.
And how so?
Its proximity to St. Vincent's Medical Center would really provide a timely response to interfacility and transfer needs in general, as well as transition needs of discharged patients.
American Ambulance has also stated that they would dedicate 3 ambulances to interfacility transfers. In your opinion, is that an efficiency?
Yes.
And why? And how so?
It's having 3 ambulances without PSA obligations that are staffed and ready to transfer or transition any number of patients to or from St. Vincent's Medical Center create operational efficiency.
And so if you were to take the location and the dedication of ambulances and not having any PSAR obligations associated with the Bridgeport branch, how would you characterize the impact on the EMS region insofar as efficiencies?
It would create a a positive impact, having a ready force to timely respond in a timely manner to St. Vincent's Medical Center, as well as other facilities for transportation in and out of St. Vincent's Medical Center.
Okay, I have no further questions at this time. Thank you, Hearing Officer Hanstead.
Thank you. Attorney Kurz, any follow-up?
Just a couple.
Sure.
Doctor, have you been aware of any time studies that have been done to determine the unavailability of any number of those ambulances due to their transporting patients away from the hospital?
I'm just going to object as to ambiguity and vagueness related to those ambulances.
Yeah,
Doctor,
Attorney Kurz,
let-
if you could just be more specific.
Sure. Doctor, did you arrive at the number of 3 ambulances based upon some determination of the frequency that it would take to transport patients away from the hospital, given the times they're typically discharged and the distance and time it would take for those ambulances to deliver the patients to where they're going?
I was not directly involved in the number of ambulances. That question may be better suited for another witness.
Okay. And you say, to your knowledge, has American Ambulance approached crews working for other ambulance companies about the possibilities of working for American Ambulance in Bridgeport?
To my knowledge, no.
And have you looked to determine whether the graduates of the Hartford Healthcare EMT programs are local to Bridgeport?
I have not looked at that specifically.
That's all I have.
Okay, thank you. Attorney Langer, anything further for this
No,
witness?
no, we're all set. Thank you.
Okay, all right. Thank you, Dr. Jandro. Attorney Langer, you may call your next witness.
Yes, I would like to call Andrew Terzic. Here we go.
Okay. Mr. Terzic, would you please raise your right hand? Do you swear to tell the truth, the whole truth, and nothing but the truth under penalties of perjury?
I do.
Thank you. And would you please state and spell your full name for the record?
Andrew, Andrew, last name Turchak, Turczak.
Thank you.
My apologies for butchering your name.
That's usually my job, Attorney Langer.
Yes, it's mine. So if I could ask you please to refer to Exhibit 2, which is American Ambulance's pre-hearing submission, which includes your resume.
Mm-hmm.
Okay, and could you please provide your background in EMS?
I started my career as an EMT working for Campion Ambulance in Waterbury from 2005 to 2010.
And after you did that, how did you, staying within the realm of EMS, what was your next position?
For EMS purposes, in my current role as Senior Vice President of Operations at St. Vincent's Medical Center in the Fairfield region of Hartford Healthcare.
Okay. And what are your responsibilities as the Senior Vice President of Operations for St. Vincent's?
I have overall responsibility and accountability for all clinical operations and financial stability and sustainability of the region.
Okay. And could you, what type of healthcare facility is St. Vincent's?
We are an acute care, a tertiary acute care medical center with 2 campuses. St. Vincent's Medical Center in Bridgeport, Connecticut, and our behavioral health campus in Westport, Connecticut.
And in your role as the Senior Vice President of Operations for St. Vincent's, are you familiar with interfacility transfers initiated by St. Vincent's,
Yes, I am.
as well as those coming into St. Vincent's?
Yes, I am.
Okay. And so interfacility transfers fall under your responsibilities as a Senior Vice President of Operations?
Yes.
Okay. And from where does St. Vincent's generally initiate interfacility transfers?
Initiate generally from either the Bridgeport or Westport campus.
Okay. And are there different types of interfacility transfers that are initiated by St. Vincent's?
There are a bunch of different ones. It could be hospital to hospital if we have to transfer. It could be intercampus between the Bridgeport St. Vincent's Medical Center and the Westport campus, or vice versa, as well as interfacility transfers to skilled nursing facilities, long-term care facilities, and at sometimes even to home.
Okay. And which healthcare facilities receive interfacility transfers initiated by St. Vincent's?
Given we have two campuses, the largest component is between our Bridgeport and Westport campus and back and forth. However, there's over 100 other healthcare facilities that we would transfer to over the course of a year.
Okay. Have you reviewed the application and supporting materials submitted by American Ambulance?
Yes.
Okay. I'm going to ask you please to turn to attachment E4, which is part of Exhibit 3, which is the corrected or supplemental filing.
Okay.
Let me know when you're there.
I'm
Good.
here.
All right, great. Could you please read the last sentence in the first paragraph beginning with "over the past"?
Over the past 3 fiscal years, St. Vincent's emergency room visits have grown to over 64,000 visits annually, and inpatient transitions have grown by 9.9% to over 15,000 annually.
Do you agree with that statement as to the approximate total St. Vincent transitions for fiscal year 2025?
Inpatient transitions, yes.
Now, I'm going to ask you to turn to attachment F of the application, which is Exhibit 1.
Okay.
Great. I have to get there as well. Okay. Do you see the list of EMS providers listed as those providers within St. Vincent's primary catchment area?
Yes, I do.
Okay. Does attachment F accurately list St. Vincent's primary catchment area?
Almost.
Why almost?
Easton's not included in here, but given that Easton's medical control is shared by both St. Vincent's and Bridgeport, I would consider them as part of the catchment area as well.
Okay. Is attachment F a fair representation of the existing EMS providers in St. Vincent's primary catchment area?
Yes.
Who are the providers handling interfacility transfers for St. Vincent's currently?
AMR and Y-axis.
And who currently handles the majority of St. Vincent's interfacility transfers?
AMR.
And approximately, what's the percentage approximately of the interfacility transfers initiated by St. Vincent's that are handled by AMR currently?
It can vary month to month, but 65% would be an accurate approximation.
And can you please explain generally how St. Vincent's initiates an interfacility transfer from its Bridgeport campus? I mean, the Bridgeport campus is the main campus, right? Okay.
Sure.
And so could you just explain generally how St. Vincent's initiates an interfacility transfer from the Bridgeport campus?
Sure. So we have care planning rounds that occur every afternoon for us to really look at and plan for the transitions that can occur the following day. And when we do identify patients that can transition to their next phase of care, confidently, we do plan and book for transportation for the next day. That is roughly about 10 to 20% of the transitions. We then also have transition rounds that continue in the morning, in which we can get more definitive transition plans for a higher majority of patients at that time. And then once we determine those, we will start to book ambulance transportation for those transitions. That would roughly be around 50 to 60% of our patients. And then there is a subset of patients that are awaiting further testing or need clinical clearance for transition that does occur in the afternoon, in which we do then book as a will call at that point, and that could be up to 20% of transitions in a given 24-hour period.
Okay. Thank you. Does St. Vincent's currently have a contract with AMR to provide interfacility transfers?
Not at this time.
How long has AMR performed interfacility transfers for St. Vincent's off contract?
Since the contract ended June 30th, 2025, so July 1st.
Okay. Now, what rate, and this was part of, the stipulation, and sure I have that. Okay, so what rate is AMR currently billing St. Vincent's for interfacility transfers? And I think a step here.
The rate is off. The rate is this one.
Yeah.
Trying to get on camera.
Yeah.
Currently, we are off contract,
Yep.
so the rate is not consistent all the time. I think I can give an example of a common transport from Bridgeport to Westport, which right now is running approximately $1,600 per trip.
Okay, and so the stipulation for one of the common interfacility transfers for off contract that we provided early this morning is accurate?
Yes.
Okay. And so you mentioned that those rates, the current rates, can vary. And could you please explain how they vary?
So the rates right now are a little bit all over the place, and we are taking the time to connect with AMR dispatch and determine kind of what cost potentially would be for patients. A couple of examples that we've had for some longer distance transfers. One, going to Boston, we were initially quoted for $6,700. When we felt that was inappropriately high, we did reach out to another provider and was able to identify that the trip could be done for $1,700. When we came back to AMR, they then decreased that $6,700 down to $2,700 as an updated cost, in which we ultimately went with a different provider. To Charlotte Hungerford, which is another transfer that transition that sometimes does occur. An estimate that we've gotten from them was $3,092. When we felt that was unacceptable, we did request a cost from another provider, and it was $760 as a couple of examples.
So in your experience currently, how do these rates that you're now being charged by AMR compare to other providers for interfacility transfers?
It could range, but 3 to 5 times higher.
Okay. Okay. So could you please refer to the second paragraph of attachment 3 to the application, which is exhibit 1. So you're in the application, just go to attachment 3.
Right.
Yeah.
Got it.
Okay.
That's
Great, sure. Would the approval of the additional branch, in your opinion, as the Senior Vice President of Operations for St. Vincent's, impact the cost effectiveness of interfacility transfers initiated by St. Vincent's?
Yes.
How so?
It would provide a low-cost provider for both our patients and our hospital to be able to transition patients.
Okay. And as the Senior Vice President of Operations for St. Vincent's, why are you supporting American Ambulance's application for this additional branch?
So right now, we are struggling with transitioning patients to their next phase of care, with the leading concern right now of having patients transition to their next phase of care that requires ambulance transportation. And this is critically important because as we are growing as an acute care tertiary medical center, we are jamming and bottlenecking throughput through the hospital to then be able to care for the patients that are seeking care or needing care, to get them into the appropriate bed to be able to move forward. Therefore, the premise of us having the American Ambulance Service within the city of Bridgeport, within 2 miles of the hospital, with dedicated ambulances to help support our interfacility transfers, I do firmly believe we would be able to improve the efficiency and the effectiveness of transitioning patients to their next phase of care.
And so you mentioned throughput issues. How do these issues with throughput for in-facility transfers impact St. Vincent's operationally?
So, I mean, we've been growing, as noted earlier, and what we submitted. I mean, and that was inpatient transitions. If we look at all patients that are spending at least a night within the hospital, I mean, that's up to 25,000 patients now. We're caring for 35% more patients in general compared to 6 years ago. Bed capacity becomes absolutely critical. And transport delays right now, when we're trying to transition patients out, that is one of the leading causes for some of our bottlenecks. The problem is when we can't remove a patient to their next phase of care, it then bottlenecks other services such as our environmental service, our food and nutrition team, and our internal transport teams, that if it's not supported throughout the course of the day appropriately, then resources become scant, only adding to the delays that we have. And when that occurs, then us being able to really care for patients, whether it be from our operating rooms that are in our post-anesthesia recovery spaces into an inpatient bed, or if it's in our emergency department, it can create ED boarding, which ultimately then reduces the amount of beds in the emergency department, which then increases wait times for patients, and ultimately, not providing the highest level of care and or experience that we expect to be able to deliver.
Are these throughput issues that you've discussed, are those related to the interfacility transfers that AMR, the current provider, is providing?
Yes.
And how long has those throughput issues, how long have they occurred?
At least since October 1st, 2019.
Okay, and I asked you to refer to attachment 3 of the application, specifically tables 1 and 2. Do you see those?
I do.
Could you just describe very generally what those tables mean?
Yeah, so these tables were provided to us by AMR, by Anthony Murrow, the GM of the Bridgeport base and location, of the on-time performance of the ambulance for interfacility transfers. As you can see, a target here that mutually agreed upon would be 90%, which we would find reasonable and acceptable. And then the different lines are for different areas of the hospital, the behavioral health, our emergency department, and or a different floor, what those times have been. And what we can see here through the general trend is a decreasing on-time performance over the course of this 2-year period of calendar year 2024 and calendar year 2025.
All right, thank you. And if you were to now turn to attachment 3, 3A, I'm sorry, and say, for example, just go to the last page of attachment 3A. It's just the October. Yeah, in that page, it shows October, November, and December of 2025. Do you
Mhm.
see that?
Yes.
What are these, what, could you please describe what these reports are?
Again, the total amount of transfers, the amount that would be considered late, the total percentage of on-time performance, and again, notating the agreed upon on-time performance goal of 90%. And once again, breaking it out by emergency department, behavioral health, non-emergency department, and if it was emergent or non-emergent.
Okay, and just to be clear, are these monthly reports that were provided to you?
Yes, these are monthly reports provided to us by AMR through 2025.
Okay. Has St. Vincent's attempted to work with AMR to improve issues with throughput for interfacility transfers?
We have.
And how so?
So, you know, AMR was really the only service provider that we used until about mid 2024. And due to continued throughput issues, you know, we did feel that we needed to bring in a different ambulance company to help support as well, but still trying to primarily utilize AMR. And with that, you know, there was feedback around what can the hospital do to improve. And we acknowledged it. I mean, paperwork not being ready, patients eating still, belongings not together, patient preparedness, nursing preparedness. It wasn't necessarily the best, but we have ourselves put together infrastructure and processes within the hospital to ensure that we're improving those things. One of the key things that we've done is created within our EMR a chat for a multidisciplinary team of that when to expect the ambulance arrival and then when that individual is there. It used to just be a phone call to the nurse, but
Yep.
it is several different parties beyond the nurse to have the patient ready. So we did create this multidisciplinary so that between case management, the provider, the nurse, they are getting these communications to be able to ensure that they're there, but also planning for the time for when the ambulance is going to be there. We've also worked on and instituted our afternoon transition rounds. Previous to 2024, we only really did those AM rounds, and that was your one touch point. We did find that if we're able to identify patients that we are confident can be transitioned the next day, that we can actually book them the night before to be able to help get those patients out. And even if that wasn't fully accomplished, it at least provided the insight to the entire team for planning for the next day on what are the critical pieces that need to be coordinated so that we can have an efficient transition the following day. So those were a couple things that we did. Additionally, with the partnership with AMR, they did provide a transport coordinator, and that individual was present at the hospital. We even actually put the transport coordinator directly into the care management office so that there was literally constant communication around our transportation needs and for that coordinator to working for AMR to help support scheduling the ambulances for us and also helping to ensure that paperwork was ready on the front end in the hospital as well, so that we were trying to make these more efficiently. But even after putting these components in, ultimately, when we're experiencing delays, the ultimate response was due to heavy 911 volume or short staffing was being the main components of the reason for delayed ambulance arrival.
Okay, and so just so I understand, when you would have conversations with AMR about the reasons for the delays, they were saying that it was heavy 911 volume and staffing delays.
Correct.
Okay. Please refer to the hospital discharges challenges work group report dated March 16th, 2026, which has been the department has taken administrative notice of.
The hospital discharge challenge work group?
Yes.
That one?
Yes.
The avoidable discharge?
Yes.
Okay.
Okay. Have you reviewed this document?
Yes, I have.
Okay. Could you Okay, and let me go to page. Let's find it. Could you go to page 16?
I am there.
Great. You beat me to it. All right. So could you please read, so we're on page 16, it says avoidable discharge delays, right?
Yes.
Okay. Could you please read aloud the first sentence starting with an avoidable discharge delay in?
Yep. An avoidable discharge delay in a hospital is the period of time a patient remains hospitalized after they are medically ready to leave, when the continued stay is caused by non-medical system level barriers rather than clinical needs.
Okay. And did you hear Dr. Jandro's testimony earlier this morning?
Yes.
Did you hear him talk about, ED discharge, ED boarding and having impacts on discharges?
Yes.
And is that statement consistent with how he described or defined ED boarding?
I'd agree. The
Okay.
ED boarding would be downstream impact to
Yeah. Okay.
avoidable discharge delays.
Okay. And do you agree with the definition in the working group report here?
Yes.
Okay. Now, do you see the caption that says key elements of an avoidable discharge delay?
I do.
Okay. I'm going to ask you, please, just to read aloud the first bullet point.
Medically ready for discharge. The patient's acute treatment is complete and they can safely transition to a lower level of care.
Okay. Has St. Vincent's taken steps internally to prevent or lessen that particular element?
We have. Again,
How so?
We've created the transition rounds, again, as noted, for the AM and PM with a multidisciplinary team, ensuring all clinical care components are addressed, ensuring the most efficient care is being delivered, and patients' length of stay is safely minimized. Those are, again, components to ensure that we don't just round on the patient in the morning and wait till the next morning to see what we have to do. We are making it truly 24/7 for that care to be optimized as efficiently as possible.
All right, thank you. And could you read aloud the second bullet point of the key elements of avoidable discharge delay?
Non-clinical barrier prevents discharge. The delay is caused by system constraints, not by the patient's medical condition.
Has St. Vincent's taken any steps internally to lessen that key element?
I mean, to me, this is where transport actually falls in, and I think this is part of why we're here today. In order to be able to help prevent that, I think you heard in my previous testimony with the previous question around the steps that we've taken.
Okay. And then could you read aloud the third key element, please?
Hospital resources are used unnecessarily. The patient occupies an inpatient bed despite not needing hospital level care.
Okay. Has St. Vincent's taken any steps internally to lessen that key element?
Well, I think first and foremost,
Is that a
yes? I'm sorry.
Thank you.
Yes.
And how so? Thank you. That's okay.
First and foremost, I think, let's talk about the ambulatory network. We have created an ambulatory network to have patients be able to have care in the right place, in the right setting, for the right cost. And we've expanded that to ensure that we now are doing more surgeries outside of the hospital and in these ambulatory surgical centers. We have an expansive urgent care model in order to be able to help prevent patients that may not have to be at the hospital to be cared for in their communities. So those are from a global perspective. Directly within St. Vincent's, we have a utilization review team and a dedicated hospitalist that is literally reviewing every single patient for the appropriateness of observation, extended stay, or inpatient status for these patients. And we appropriately admit patients and efficiently provide necessary medical care while creating their plan for their next phase of care transition while we're caring for them in the hospital.
All right, thank you. Now, I'm just going to ask you to look down page a bit, and do you see the caption that reads, common causes of avoidable discharge delays?
Yes.
Okay. I'm just going to ask you again, just could you read aloud the first bullet point under that caption?
Yes.
Please.
Post-acute care placement delays, no available skilled nursing facility, rehab bed, or home health capacity.
Has St. Vincent taken any steps to internally to prevent or lessen that common cause?
Yeah, I mean, and I think it's fair to say that is a common cause, but our case management team has a constant pulse around all our rehab and skilled nursing facility beds, and our partners and strong relationships built over the years have really helped us be able to identify and maneuver and be able to figure out which beds are available to offer to our patients to accept going to. From the home health standpoint, we've invested in our Hartford Healthcare at Home program in order for us to be able to ensure that we have that ability to care for patients by sending them home.
Okay. And could you read aloud the second bullet point under common causes?
Medicaid or insurance authorization delays pending LTSS eligibility, prior authorization, or funding approval.
Has St. Vincent's taken any steps internally to lessen that common cause?
Yes.
And how so?
So, I mean, I think we should be honest that the payer auth certainly is a barrier. It's a barrier for everybody. And it does delay payers in creating and providing authorizations, which somewhat are out of our control. But what is in our control is to ensure that we're prepared for these payer delays, ensuring that we have all the paperwork done, medical necessity completed, and we also have our clinicians available for peer-to-peers to most efficiently respond to the authorization process by these payers to be able to expedite as quickly as possible.
Okay, thank you. Could you read aloud the third common cause, please?
Guardianship or conservatorship issues, legal decision-making authority not yet established.
And has St. Vincent's taken any steps internally to lessen that common cause?
Yes, again, from an investment standpoint, where we want to ensure to be able to improve efficiency, we have actually now a medical legal counsel that is able to support us 24/7 on call with helping mitigate any of those type of issues.
Okay. And now the fourth bullet point under common causes. Could you read that aloud, please?
Yep. Behavioral health capacity shortages, no psychiatric bed or community program available.
And has St. Vincent's taken any steps internally to lessen that common cause?
Yes, we have one of the most robust behavioral health programs in the entire state. We actually just in October increased our Westport Behavioral Health Campus by 8 beds to improve capacity and access there. We also have our inpatient behavioral health floor at St. Vincent's and our behavioral health unit in the emergency department as well. We do have our community psychiatric centers to support outpatient. And just this year, we also launched our partial hospitalization program to also enhance access and care for behavioral health patients.
Thank you. Could you please read the next to last common cause aloud, please?
Housing instability, patient is medically ready but has no safe discharge destination.
All right. And has St. Vincent's taken any steps internally to lessen that common cause?
So we have actually created a dedicated complex care team specifically for these type of patients that do have these, social inequities or instabilities. This team holds progression rounds on a daily basis with dedicated resources to help and assist patients through those concerns.
All right. And then finally, the last common cause. Could you please read that aloud?
Transportation or logistical barriers, delays in arranging medical transport or durable medical equipment.
All right. Has St. Vincent's taken any steps to lessen that common cause?
From a durable medical equipment standpoint, where we used to partner with third parties and to rely on them, we now insource durable medical equipment, and we are able to, which we stock, provide to the patient, and then ultimately bill insurance or patients afterwards. For patients not requiring ambulance transportation, we've actually made an investment into the Ride Health program, which is a transport service that can assist patients getting back to their home, in which the cost is actually picked up by the hospital. And then for patients requiring ambulance transportation, although we have continued to work and partner, this is why we believe the American ambulance service and the opportunity for them to be in Bridgeport and to service us, that would be the other component of resolving transport delays.
All right, thank you. So how did St. Vincent's get involved with American Ambulance's application for an additional branch?
So these concerns have been raised, obviously, over the years. And our director of EMS, Wes Young, brought it to my attention along with our case management director, Bonnie Stanton, of continued backlogs and log jams of us not being able to get patients through to their next phase of care due to transportation delays. And again, as you have heard, we have tried to work internally. We have put the effort in to improve upon the processes that we can control. But ultimately, we did reach out to Dr. Jandro as the EMS system director to think creatively and try to think of it from a system perspective of what opportunities there may be for us to be able to help support. And then after some level of investigating and seeing resources that may be available, we were able to connect with Josh from American Ambulance that ultimately connected with Wes and was able to offer this type of solution for us.
In your opinion, as the Senior Vice President of Operations for St. Vincent's, would having American Ambulance handle interfacility transports initiated by St. Vincent's improve service in the area, including cost effectiveness and response times?
Yes.
And how so?
The dedicated ambulance who have a sole focus without the 911 responsibility to be focused strictly on helping the hospital transition patients out is second to none. It would have improved timeliness based on the base location being so close to the hospital. And it also provides us a fixed low cost option that we know that we could budget for appropriately.
I'm going to ask you to go back to attachment E4, which is actually in the supplemental pre-filing exhibit, which is exhibit 3.
E4.
E4, yep.
Okay.
All right. Great. So approximately how many interfacility transfers is American Ambulance proposing to perform for St. Vincent's if this application is approved?
Approximately 5,400 and expected to grow year over year with our growth.
Okay. Is that the majority of the interfacility transfers initiated by St. Vincent's that St. Vincent's projects over the next 12 months?
Yes.
Would St. Vincent's still rely on other providers to handle interfacility transfers in the event this application is approved?
Absolutely.
Would these other providers include, for example, AMR?
Yes.
Now, since American Ambulance's application contemplates covering the majority of St. Vincent's interfacility transfers, in what way would St. Vincent's rely on these other providers for interfacility transfers if this application is approved?
So I think this goes back to this adds a resource into the region for us to be able to utilize. And yes, we can and would use American as the primary service to be able to help provide the transitions. We also fully appreciate that there will be times that our transition needs in any given day are going to be more than what American may be able to handle. And we certainly are going to look to the other ambulance companies to help support us. And that includes AMR. Again, our goal is to be able to have the most efficient and cost-effective transport for our patients that are ready to transition and for us to operationalize this with all of our ambulance partners.
In your opinion, as the Senior Vice President of Operations for St. Vincent's, in your opinion, how would having American Ambulance provide interfacility transfers for St. Vincent's impact AMR?
I I would think positively from my perspective. And what we hear that 911 calls and the burden and the amount of 911 calls that there are as being the number one reason for delay. We believe by having 3 dedicated ambulances by American there would free up AMR to be able to serve the PSA and handle the 911s. We also believe that it would extend beyond that because right now there's a significant amount of mutual aid coming into the city from smaller community ambulance services. And by doing so, it would likely help reduce some of the mutual aid necessity into the city, while also allowing those services of the other community service providers to really remain in service within their communities.
And would your answer be the same for other EMS providers, other than AMR in the region?
Yeah, I mean, I think going back to those other community service that we saw in our catchment area, those other service providers where they are having to come into the city to be able to provide mutual aid. If AMR was more available for 911s, I believe it would reduce mutual aid request and allow those ambulance services in those communities to remain in their communities to serve those communities.
Have you had the opportunity to review AMR's initial pre-filed testimony?
Yes.
Okay. I'm going to ask you please to refer to AMR's pre-filed testimony, which I believe is dated May 29th. It is May 29th.
Okay.
Okay. Take your time.
Okay.
All right. Take your time. Let me know when you're there.
I'm there.
All right, great. Could you please turn to page 3 of, well, first, let me just ask you, so you reviewed this pre-filed testimony submitted by AMR May 29th?
Yes.
Okay. Could you please refer to page 3 of Mr. Scheidinger's testimony?
I'm there.
All right, do you see paragraph 20?
Yes.
Okay. In your opinion, as the Senior Vice President of Operations for St. Vincent's, would an American Ambulance additional branch increase paramedic and EMT staffing difficulties in this region?
I don't believe so.
And why not?
I mean, just alone for what we are doing to help increase the supply of EMTs and paramedics. St. Vincent's alone partners with University of Bridgeport that offers 3 EMT courses a year, 2 with Sacred Heart University. St. V's offers an additional one. And we're starting another program with Harding High School to also start an EMT program for high schoolers. To date, in the last 1.5 years, we have certified 125 EMTs, and that's just the EMTs. Then there's the paramedics, in which we have 1 class a year where we've had 4 classes to date. We've graduated 32 paramedics with 22 currently enrolled. So from my perspective, we are taking in our own hands to help increase the supply of EMTs and paramedics, not only potentially for American, but for the entire region.
Thank you. I'm going to ask you now to look at paragraph 21 of Mr. Scheidinger's pre-filed testimony. It's page 3. Do you see where he says that AMR has served St. Vincent's for decades?
Yes.
Okay. So why now is St. Vincent's open to having American Ambulance perform interfacility transfers initiated by St. Vincent's?
So we definitely have a longstanding relationship with AMR and are appreciative of that relationship. And we have no intention of trying to end the overarching relationship. I just want to make sure that's clear. We still expect to utilize AMR in supporting our work around transitioning patients from the hospital. But especially over the last 5 years, the data tells the story in which the on-time performance and timeliness is impacting our operations to be able to effectively have effective throughput of our patients out of the hospital and for us to make the next available bed for the next patient. And ultimately, right now, we are trying to look at creative and different type of solutions by having American come into Bridgeport, increase the supply of ambulances, ultimately 3 dedicated ambulances, 2 interfacility transfers located locally with close proximity to St. V's, which ultimately, by creating efficiencies, will help our throughput and decrease bottlenecks through our hospital.
So, in your opinion, as the Senior Vice President of Operations for St. Vincent's, in your opinion, is there a need for an additional American Ambulance branch location 2 miles from St. Vincent's Bridgeport campus?
Yes.
Why so?
The branch, again, being located 2 miles from the hospital, allows for efficiency to be gained by literally that proximity. And that in itself would be a significant component. That branch would be necessary.
And in your opinion, as the Senior Vice President of Operations for St. Vincent's, how would you characterize the impact that American Ambulance performing those interfacility transfers from the proposed branch have on St. Vincent's operations?
So again, not to sound like the broken record, but I think it has to be stated. Dedicated ambulances for interfacility transfers located proximally to the hospital that are not required to, you don't have the PSA for the 911s, will improve quicker response time to the hospital, improved on-time performance. We'll be able to transition patients more effectively. It'll decrease bottlenecks, which ultimately will decrease ED boarding, decrease ED wait times, and get patients into the right spaces that they need to be.
In your opinion, how would having American Ambulance perform the projected amount of interfacility transfers impact patients at St. Vincent's and in the Bridgeport EMS region?
So starting globally from the EMS region, by having these ambulances, it will allow for AMR and community ambulances to be more readily available to respond to 911s, with likely reducing mutual aid necessity. How it will impact patients at the hospital. It's going to reduce wait times. It's going to reduce boarding. Patients get to the location that they need for their clinical needs. It's going to improve patient experience. And it allows us to care for more patients in a more timely manner with a humanistic experience that our communities need and deserve.
All right. And so we discussed the report of the Hospital Discharge Challenges Working Group, specifically some of the systemic issues that are facing hospitals like St. Vincent's. In your opinion, as the Senior Vice President of Operations for St. Vincent's, if approved, would the additional branch address some of the challenges facing St. Vincent's regarding avoidable discharge delays?
Yes.
And how so?
As we discussed, we put a lot of work and resources behind addressing multitude components of throughput delays. And right now, ambulance transportation is still one of them. And at this time, by having American come in and be able to provide a base with dedicated ambulances without the 911 necessity located close to the hospital, we really do feel that this will support our transitions greatly, impact our throughput, alleviate the bottlenecks, and allow us to more expeditiously care for patients at St. V's and the Fairfield region.
All right. Thank you very much. I don't have any further direct at this time. I just reserve the right to redirect. Thank you.
Okay. Thank you, Attorney Langer. Attorney Kurz, I imagine you have some substantial cross-examination for this witness. You're muted.
Needed.
I do, but you don't have to hear any of it if I'm muted.
Okay, so why don't we do this? If nobody has any issues with it, why don't we break for lunch now, and then when we come back, we'll get to the cross-examination. Is that okay with everyone?
Works for me.
Yes.
Thank you.
Okay. All right. So we're off the record until, let's say, 1 p.m. Thank you, everyone.
Thank you.
Thank you.
Okay, let's go back on the record, please.
We're here.
Okay. Attorney Kurz, you may proceed.
Thank you. Can I get you? I think I have successfully shared my screen, and you should be looking at a page from the Hospital Discharge Challenges Working Group document. Can you see it on your screen?
We cannot, but we do have the document available, so we'll just pull it up.
Okay, so page 13, and I'll put that back up if anybody was able to see it.
I could see it.
Okay,
I could see it as well.
Ah, all right,
Okay.
then it's an issue with us.
so I'd like to ask the question, are you familiar with the available bed figure and the boarding figures that come from the Hospital Discharge Challenges Working Group report?
I see it in the report.
You believe the information is accurate?
I know that to say we have 363 available beds is inaccurate.
So this is 224 data. So I'm not asking you about the accuracy of the current situation. Do you think it was accurate in 2024?
In terms of staffed and available beds, that number would not be accurate in 2024.
Okay, so what you're saying is the hospital may not staff beds that it's licensed for, and as a result, the occupancy of available bed figure can be off. Is that what you would testify?
We staff to all the available beds that we have beds for.
And what's your understanding of the number of beds you staff?
We have of inpatient beds, and if you remove specific components of it, it would be around 260.
Okay. And add back those specific components, and what would the number of beds be?
Likely roughly around that number. But that includes bassinets, to be clear, that includes bassinets, NICU beds, not adult inpatient beds, what we would be adding back.
So you'd be getting back to the number of 363 available beds, right?
Close to that.
And patients in those beds might be premature infants, and they might be the most senior members of the community, correct?
If you're including all beds, then yes, it would, yes.
Do you also agree that your boarding numbers are as good as most of the hospitals in the state?
I'm not sure how that data calculation is made. I could say that we feel higher than that number.
So what you're saying is that on a day-to-day basis, you are worried that your throughput, that patients getting out of the hospital are not getting out as fast as you want. That's basically what you're saying.
Yes.
You are not an emergency medical services person, right? That's not your role at the hospital.
Emergency medical services ultimately report up to me.
Okay. And in their reporting up to you, who are the reports?
Can you explain that, please?
Who is reporting up to you?
Director of EMS.
And what are they reporting up to you about?
Can you clarify what you mean by that?
What do the reports consist of?
Can you repeat that, please?
What do the reports consist of?
So I have a direct report who's the director of EMS that reports to me.
Has the director of EMS informed you about any ongoing contract negotiations between St. Vincent's and American Medical Response?
American Medical Response, yes.
And there are ongoing negotiations, is that correct?
Yes.
You understood that at the time the last contract with AMR expired, you were getting a better rate on transports to your Westport facility than what American Ambulance is proposing, correct?
Per the stipulations, those were what was entered as a stipulation.
Right, and I'm asking you, you understood that the contract rate that you had with AMR is better than the contract rate, it's better than the rate that is being offered you by American Ambulance, right?
If we are comparing a 2021 contracted rate to 2026, yes.
Okay, now you tell me if that 2021 rate was what you were paying in June of 2025 for the transports to Westport.
Yes.
Okay, so there's no reason for you to believe that the next contract would be much above the rate that you were paying in June of 2024, correct?
Objection, speculation.
I'm asking him if he has any reason to believe that the rate would have been higher. I'm not asking him to speculate.
It calls for speculation.
I'll sustain the objection. It does call for speculation.
Are you aware of what rates are being discussed with AMR now for a future contract?
Yes.
Okay. And are you aware whether those rates are more favorable than what American Ambulance is offering you?
I will object to the extent that ongoing negotiations regarding a potential contract is one, involves proprietary information, and two, is not relevant material to whether there should be an additional branch.
And I would say it's relevant and material to the extent that American Ambulance is relying upon the notion that it's got a better rate to offer St. Vincent's than St. Vincent's can get from AMR.
Yeah, I agree with Attorney Kurz in that respect, but if there's no contract entered into at this time between AMR and St. Vincent's, I don't know how I would, compare those rates because they don't exist, right? And I don't want to base that comparison on something that may or may not come to fruition. So I'm going to sustain the objection.
Who will decide on whether a new contract is entered into with AMR? At what level is that decision made?
My level between my level with consultation with our EMS system partners.
Okay. So in the same way that you've gone shopping for better rates when you haven't liked what AMR has told you it would cost you for a transport, you're in the driver's seat as to determining what that price is that AMR would put in the contract in order to get that contract agreed upon by you, correct?
I object to the characterization.
Yeah, I'll sustain the characterization, but the witness can answer the question.
Can you repeat the question, please?
And Mr. Hearing Officer, I'd like
Yes.
to not have the situation where every time Mr. Langer objects, there's a request to have the question repeated. It has almost been uniform since the hearing began.
Yeah, to the extent that's possible, but if they don't understand the question, they have the right to ask that it be repeated. So I want them to understand the question before they answer it.
You're the person who's going to decide whether the new contract is entered into with AMR, right?
Yes.
A priority for you in deciding whether to enter into that contract is the price of transports from the Westport facility to St. Vincent's and from St. Vincent's to the Westport facility, correct?
It is a component.
Okay, it is a component. So you are, you agree that there's nothing stopping you if you can reach an agreement with AMR from getting a better rate than what you're being offered or proposed by American Ambulance, correct?
Just going to object to the extent that it calls for speculation.
Yeah, I'll overrule
I'll ask
that.
it
He can
differently.
answer.
Okay.
All right, go ahead.
Answer.
We are in active contract negotiations with AMR as we still want to maintain partnership with AMR and to ensure that we are creating a uniform opportunity to ensure we are going to have an efficient and an effective model of transitioning our patients out of the hospital. Cost is a component of that, but not the only component of it, and certainly not the only reason why there would be a contract signed one way or another.
Is it your intention to enter into a contract with American Ambulance for the service that they're proposing be provided in this application?
We have not discussed contract terms yet.
My question is different. Do you intend to let me ask a different follow-up question. Do you intend to discuss contract terms with American Ambulance?
Yes.
And do you intend to have metrics in that contract that extend beyond the priority one on-time performance metric?
Yes.
So if your boarding number is as low as is shown, have you engaged in any conversations with Bacchus Hospital about fixing its boarding situation in the same fashion that you've undertaken?
I'm just going to object to the question and that you're referring to a boarding number that goes back to 2024. So I just think that needs to be clarified in the question. So it's vague and ambiguous.
So Attorney
Well,
Kurz, are you referring to the 2024 number?
No, what I'm referring to is the 2026 reality. Do you have any reason to think that in 2026, Bacchus has improved its boarding situation?
I'm going to object to that it's not relevant material to whether there should be an additional branch in the Bridgeport EMS region.
I'll allow the question. The witness can answer.
It would be full speculation. I'm not sure.
There are different kinds of transports out of St. Vincent's besides ambulances, right?
You mean transitions out of the hospital that don't use an
Right.
ambulance in general? Yes.
Right. So those can be a personal vehicle of a family or a friend, correct?
Yes.
And when the family or friend gets there can affect when exactly the patient gets out of the hospital, right?
It could play a role.
Okay. It could be a non-emergency medical transport taxi service, right?
Yes.
And you're familiar with the existence of those, right?
Yes.
Does the hospital underwrite any of those transportations by those taxi services when it wishes to have a patient get out of the hospital sooner?
We do have a ride health program that does support having patients leave the hospital that can without stretcher assistance.
Just on a daily basis, what's the number of patients who get discharged?
It can range from 40 to 60, at times a little bit higher.
And of that 40, is the percentage that is an ambulance, or is the number that typically requires ambulance transport is closer to 5?
I would just, I guess, object to the mischaracterization of the testimony. It was 40 to 60 discharges per day and sometimes higher. I think you just referred to 40.
Okay.
So the witness can answer the question.
It is more than 5 a day.
And what does that range run in your as you think of it?
Again, this is not it's rough estimate, 10 to 20.
There are wheelchair livery services that take patients away from the hospital too, correct?
Yes.
And there are other livery vehicles that do the same. Is that right?
What do you mean by other livery vehicles?
Livery that doesn't require a wheelchair.
If you're referencing like our ride health program, yes, but other than that, I wouldn't know another livery type of what you're speaking about.
Have you evaluated what percentage of delayed departure are associated with transportation as opposed to other factors?
We have evaluated it.
And there are numbers that are associated with the type of delay?
Due to transportation, yes.
Okay, and what number do you associate with transportation delays?
Don't have that in front of me right now to give that hard number.
Do you have an estimate of the number?
It would, at this moment, it would be speculation, 30–40% of all discharges.
I mean, if that's something, a number or percentage that we can get, maybe we could present that as a late file. Is that doable? Hearing Officer Hanstead, do you want us
Yes.
to maybe provide a less speculative number so that that can be part of the record?
I always prefer something that's not speculation. So yes, if you can get that and file it with my office, let's see.
Okay.
How long do you need to file that?
The week,
A week, yeah.
yeah, a week, please.
Okay, and just so there's no confusion, Attorney Kurz, would you specify what you're seeking in that answer?
I'm seeking the analysis they've done of the causes of delayed departures from the hospital.
It was the number of delays due to transportation, is what I recall being the question.
Yes.
Yeah.
Well, I think it would be of value to have the entirety of their analysis to the extent that there are other sources of delays that they've delineated and calculated.
Yeah, so I agree with you both in that respect. It was the original question asked for a percentage. Well, he gave a percentage answer, so it wasn't an analysis, but I think the complete analysis would be more beneficial to me in reviewing this application. Is that something you can provide?
I'll have to confer about that and just make sure that there's nothing in there that is considered proprietary. And if not, then sure, we would certainly provide that.
Okay,
So
and even if there are certain portions that are proprietary, you can redact that
Redact.
as long as the document still is meaningful when it's filed. So why don't you confer with your client at our next break, and then we can revisit this issue.
All right, thank you.
You're welcome. Okay, Attorney Kurz, you may proceed.
You heard your colleague, Dr. John Rowe, talk about the priority one responses to patients at the hospital. And I considered him to be talking about the emergent request for transports. Is that how you understand priority one?
Yes.
And have in reviewing the monthly summary reports that you receive from AMR, you would agree that for priority one, it is typically the case that the timeliness is 100% on-time performance, with some exceptions, correct?
I would just, if it's okay, Attorney Kurz, I'm just going to ask him to refer to attachment 3A to be able to respond to your question.
That's okay.
All right, so I'm looking at the data, so please ask that question again.
Okay, so typically the emergent designated response is at 100% of the on-time performance, correct?
You should go through it.
Give me a moment to review it. Yes, it's accurate.
You don't have any responsibility for budgets for any ambulance service that is owned or operated by Hartford Healthcare, correct?
Correct.
So you have no concern with the fact that this proposal will cost $2.4 million plus for American Ambulance to operate the branch location it's asked for, correct?
I wouldn't say I don't have a concern. Again, that's not my business on that end of it. So I believe you'd have to ask the appropriate party for that.
Are you aware of any aspect of the costs that are going to be incurred by American Ambulance being paid for by St. Vincent's?
I'll object to the question to the extent that it requires any attorney-client privilege. It requires the disclosure of proprietary information. And I would also object on it being relevant and material to whether there should be an additional branch.
It is highly relevant material. I'm sorry.
Yeah, I'm going to allow the question. Just don't disclose any confidential information.
I'm aware that there will be a cost to American to be able to set up a branch. The details of those costs, I'm not aware of.
And the question was directed at something a little bit different. Are you aware that St. Vincent's will pick up any of those costs?
St. Vincent's will be paying for the services that American is providing. Those are the costs that St. Vincent's would have.
Now, the only services that St. Vincent's is paying for are the inter-facility transports to Westport, correct?
Again, because we have not discussed contract terms, I cannot say that definitively.
And I'm not asking about contract terms. I'm only asking, are you aware of any intention by St. Vincent's to underwrite American Ambulance's branch location?
To date, no.
And you are not, let me ask you this. You have no concern how American Medical Response meets its expenses whereby it no longer can rely upon the transports that it had been doing from St. Vincent's. Not a concern of yours, correct?
I'm looking for a solution for us to be able to provide reliable transportation needs for our patients to be able to be discharged from St. Vincent's and for us to improve throughput.
So you don't have an opinion about the effect upon the sustainability of the existing EMS services in Bridgeport and Fairfield as affected by the loss of transports for AMR?
As stated previously, I believe that by adding additional ambulances will help support the EMS ecosystem within the region, and making more crews available for 911s. I mean, that's my response.
And you have no concern about there being an overcapacity of vehicles in Bridgeport as a result of the additional vehicles being added by American Ambulance?
No.
You have no opinions about what a expected number of mutual aid responses should occur in the Bridgeport PSA, right?
No.
So in saying that the PSA is going to benefit from the availability of additional mutual aid services, you're not aware of whether those mutual aid services are being adequately supplied by other providers presently, correct?
I'm aware that there's mutual aid coming in from smaller communities around Bridgeport to help Bridgeport with their 911 coverage.
And do you agree that it's the appropriate thing for the primary service area responder to do, to have a call taken by the mutual aid provider when the mutual aid provider is closer, or because for instance, the AMR ambulance is otherwise occupied?
If there's an emergency and someone needs assistance, I think it needs to be whoever is able to respond.
Right, and that's not a problem with the system. That's the way the system is expected to work, right?
Yes.
And that's not a problem with the service that AMR is providing to Bridgeport. That's the way it's supposed to work, right?
I would be speculating on an answer to that. However,
Okay. No, I'm not asking for speculation. So if a patient is eating, that delays when they get out of the hospital. If the discharge hasn't been accomplished by the time lunch gets delivered, correct?
say that again, please.
One of the reasons you gave for a discharge being delayed was a patient eating, right?
That was brought to our attention as patients weren't ready previously. That was one of the
And
things.
that's one of the things that throws off your throughput, right? That's the language.
We have improved that patient readiness, we have drastically improved.
Okay, so there's patient readiness, there's paperwork readiness, right?
Correct.
Okay. And those are reasons that your patient throughput may not have been what you wanted it to be, that are unrelated to transportation, right?
No, I disagree with that.
You track the multiple factors that enter into the delay of any particular patient departing?
We attempt to.
Are you aware of the hospital having to answer to any Department of Public Health investigations of complaints by a patient that their departure was delayed from the hospital?
I mean, I'll object to that to the extent that it is not relevant material, to the extent that it raises attorney-client privilege, to the extent that it is, yeah, those are my those are the two bases for objecting.
It is relevant material because multiple witnesses now have explained how patients are being put at risk by these delays. I'm just asking whether they have any proof that patients have made complaints because they believe that they were put at risk. And there's no attorney-client privilege element to it.
Yeah, no, I mean, to the extent that there is, don't answer, but to the extent that there is an attorney-client privilege, you may answer the question.
To my knowledge, no.
Besides Department of Public Health related complaints that have been brought to your attention, which you say there have been none, have there been privately communicated patient complaints that have been communicated by or on behalf of the patient to the hospital about negative physical effects of them upon due to any delayed leaving of the hospital?
There have been communications from patients complaining about transportation delays.
And have you brought those to the attention of AMR in each instance?
I personally have not, but to my understanding, our director of EMS has.
And do you know if those have been solely directed at AMR?
I am not aware.
Have you looked to increase the amount of activity by Y-axis at the hospital?
I missed the beginning part of that question. I'm sorry.
Have you looked to increase the level of transportation activity by Y-axis at St. Vincent's?
Over the last 6 to 8 months, yes.
Okay. And what's been the result of that effort over the last 6 to 8 months?
Y-axis has been more reliable.
Is there any reason to think that they are unable to be the primary provider to St. Vincent's?
We have engaged around we've engaged around a contract, and at this time, there is no interest on their end, provided their recent acquisition.
But they're happy to still do the work without a contract. Is that it?
Happy to do the work, not committing to do the work.
They will make a judgment whenever they get a call as to whether they can provide the service that you're asking for, correct?
Correct.
Do you have any practice of calling Y-axis first before calling AMR? Presently,
At times, yes.
is there any established practice within the hospital as far as when they call Y-axis and when they call AMR?
Historically, based on old contracts, the Westport and ED transitions were given to AMR, and then some of the floors given to Y-axis, and AMR having the rest of the floors. When it was contractual, we would stick to that. At this time, and in the position that we're in, we do try to source the cheapest as well as the most efficient transport provider at this time.
And have you made a determination that Y-axis is is cheaper than AMR?
At this time, significantly.
Have you made a determination that Y-axis is more efficient than AMR?
Provided and based on feedback, yes.
And is it your expectation that E-Access will continue to provide services to St. Vincent's?
The same as I would expect AMR to do so.
And you're completely satisfied with Y-Access's services?
I wouldn't say completely, but I would say more so.
What's your level of dissatisfaction?
Low.
That's all I have.
Okay, thank you. Attorney Langer, any redirect?
Could I have just 5 minutes just to
Sure,
make sure?
sure. Let's take a little bit longer. Let's take a 10-minute break and we'll adjourn until 1:53. We're off the record.
Thank you.